Let's begin. I would like to show you today presentation about differences between primary and permanent teeth and dentition. This term is usable in all fields of dentistry: therapeutic, prosthetic dentistry, orthodontics, restorative dentistry, gnatology. So let's continue about crown morphology. Contact area or approximal surfaces. Temporary teeth have a small contact area placed more gingivally. Instead of permanent teeth, have large contact area, and they are placed either in the middle third or at the junction of the middle and incisal third, in area of equator crown part. Schematically, temporal teeth have small contact area in the gingival third. Instead of permanent teeth, have large contact area in the junction of middle and incisal third. What does it mean in practice? Features of contact area. In therapeutic dentistry, it means that to get nice restorations, nice composite restorations, we must use preformed special preformed metal matrices with special rings to get tight approximal contacts between restorations, step by step. And final result. They are shown position of contact areas in temporary teeth, and in permanent teeth and permanent restorations near middle part of crown height. Or area between middle and occlusal parts of thirds, crown thirds. X-ray and a vital photo. And multiple restorations in therapeutic dentistry. As can you see, a doctor used preformed metal matrices with special rings, and as a result, doctor created thigh approximal contacts. As for me, the better than natural teeth were. But what does it mean in features of contact area position in prosthodontics? Our dental laboratory, and we, like doctors, need to create approximal contacts between our prosthodontic restorations, like artificial crowns or bridges. What about next characteristic of crown morphology, like cervical line? Temporary teeth cervical line is less curved. Instead of permanent teeth cervical line is more curved. Schematically, temporary teeth cervical line is mild curve. Instead of permanent teeth cervical line is more curved. Next characteristic of crown morphology is cervical ridge. The cervical third of the crown, cervical ridge of temporal teeth are prominent. Instead of permanent teeth cervical ridge are less prominent. For temporary frontal teeth, the oral area for more prominent for temporary teeth and less prominent for permanent teeth. A very important characteristics: cervical constriction. In temporary teeth, cervical constriction is marked. In permanent teeth, less pronounced. So, schematically, marked cervical constriction in temporary teeth and less pronounced cervical constriction in permanent teeth. Let's go deeper from crown part to the root part of tooth. And let's compare characteristics of roots in temporary and permanent teeth. Length of roots in deciduous teeth, they are shorter and slender. In permanent teeth, longer and stronger. Schematically, Temporary teeth have short and slender roots. Permanent teeth have long and strong roots. Crown root ratio. In temporary teeth, roots longer compared to the crown size. Comparatively, roots in temporary teeth are longer. But in temporary teeth, crown root ratio is different, and roots in permanent teeth are not as long as crown size. Schematically, in temporary teeth, roots are longer compared to the crown size, but ratio of crown root in temporary teeth not as long as crown size. Next root morphology characteristic, inclination. Inclination of roots in temporary teeth is slightly labial, as much as 10 degrees seen in the apical third of the frontal teeth roots. Permanent teeth don't show any labial inclination. What does it mean schematically? Temporary teeth root. Slight labial inclination of the root as much as 10 degrees seen in the apical third of the frontal teeth roots. Instead of permanent teeth, don't show any labial inclination. Next characteristic, level of forcation. In temporary teeth, level of forcation or dividing roots are near the cervix. Instead of in permanent teeth, the level of forcation of the root is about 3 or 4 mm from the cervix, or is more apically placed. Schematically, it looks like here. Point of forcation. In temporary teeth is near the cervix. Instead of point of forcation of permanent teeth roots is 3-4 mm from the cervix. Next characteristic of root morphology, root trunk. In temporary teeth, root trunk is not distinct, but in permanent teeth, trunk is long and distinct. Schematically, it looks like here. Not distinct. Trunk in temporary teeth instead of long and distinct trunk in temporary teeth. Next characteristic, root flare. Temporal teeth. Flare beyond the mesiodistal and buccolingual outline of the crown to allow space for development of the permanent tooth crown. But in permanent teeth, roots don't flare and are well within the boundaries of the crown. Schematically, it looks like here. Temporal teeth root flare beyond the mesiodistal and buccolingual outline of the crown to allow space for development of the permanent tooth crown. Instead of in permanent teeth, roots don't flare and are well within the boundaries of the crown. What does it mean practically? In surgical dentistry, please, doctors, don't forget that under temporal teeth and between temporal teeth roots are placed follicles of permanent teeth. And please don't forget main rule of pediatric surgical dentistry. Don't use elevator to extract temporary teeth. Don't use elevator to remove temporary teeth. To avoid permanent teeth follicles damaging or removing. Don't use elevator in pediatric surgical dentistry. And use only forceps. Only forceps. Let's go deeper inside of tooth and let's talk about pulp morphology. Pulp chamber in temporal teeth is comparatively larger when compared with the size of crown. But in permanent teeth, pulp chamber is relatively small, not absolutely in millimeters, but relatively in compare with size of crown part. Pulp horn in temporal teeth. Pulp horn is extend more incisally or occlusally, and they are placed close to the enamel. Instead of permanent teeth, pulp horn not placed at a high level as in deciduous teeth. Schematically, it looks like here. In temporal teeth, pulp horn extend more incisally or occlusally, and they are placed close to the enamel. Instead of permanent teeth, not placed at a high level as in deciduous teeth. I'm sorry. What does it mean in practice? Size of pulp chamber. In therapeutic dentistry, in a stage diagnosis. Diagnosis deep caries in temporary teeth is incorrect. Please don't make diagnosis deep caries in temporary teeth. Please don't be not qualified doctors. Diagnosis deep caries in temporary teeth is wrong. And I would like to show you this table with diagnosis about caries and compare temporary and permanent teeth. Diagnosis initial caries is correct for temporary and permanent teeth. Superficial caries. We can make this diagnosis in temporary and permanent teeth. Diagnosis moderate caries will be correct for temporary teeth and for permanent teeth. What about deep caries diagnosis, doctors? Could you help me? For temporary teeth, for permanent teeth, this diagnosis will be correct. But for temporary teeth, diagnosis deep caries will be wrong. But what about deep complicated caries? Could you help me? Can we make diagnosis deep complicated caries for temporary teeth? Yes or not? You are wrong. What does it mean, deep complicated caries? Deep complicated caries, it means pulpitis or periodontitis. And temporary teeth can have deep complicated caries like pulpitis and periodontitis. And of course, permanent teeth can have diagnosis deep complicated caries. So in a stage of caries management, practically pulp chamber features. We need use methods for deep caries treatment. And please remember it that they are not used methods for deep caries treatment in temporary teeth. Next characteristic, root canals. In temporary teeth, root canals are wider and tortuous. Instead of in permanent teeth, root canals are narrow. So, schematically, wider and tortuous root canals in temporary teeth and narrow root canals in permanent teeth. Next morphological feature, accessory root canals. In temporary teeth, accessory root canals more in number and situated in furcation area. Instead of in permanent teeth, accessory root canals are present mainly in apical region. Next characteristics, root dentine and cementum thickness. In temporary teeth, root dentine and cementum are thinner. In permanent teeth, root dentine and cementum are thicker. Next very important feature, apical foramen. In temporary teeth, apical foramen is larger. In permanent teeth, narrow and constricted. What does it mean in practice? In therapeutic dentistry, in complicated caries management. Let's mention again, complicated caries, it means pulpitis and periodontitis. It is clinical situations when we need to treat root canals. What about management of root canals? Let's go step by step. Endophiles, root canal files. For temporary teeth, we must choose bigger sizes. For permanent teeth, smaller sizes. Bigger sizes for temporary teeth and smaller sizes for permanent teeth. Could you tell me, doctors, what size number they are shown on this picture? Red mark, it can be or 25 size number 25, or next step 15. But what size? White color, it means or 15, number 15. Or 45. They're shown size number 15. Ultrasound methods of root canal treatment. We must use more careful this method in temporary complicated caries treatment, but standard use in case of permanent root canal treatment. They are shown ultrasound device from Mega company. I use this device many years with great pleasure. And root canal irrigation. We must choose bigger irrigation needle size for temporary teeth root canal treatment and smaller irrigation needles size for permanent teeth root canal treatment. They are shown smaller size bigger size, smaller and bigger size. Please mention that yellow color is smaller than gray color. Everything and everywhere. What about accessory root canals? Let's repeat. More in number and situated in furcation area. Accessory root canals are more in number and situated in furcation area. Instead of in permanent teeth, accessory root canals are present mainly in apical region. What does it mean in practice? In therapeutic dentistry clinics, complicated caries management. For high-quality root canal treatment, the use of microscope is necessary. As can you see, they are shown upper first permanent molar with 5 root canals. What about root dentine and cementum thickness? Let's repeat. In temporal teeth, thinner. In permanent teeth, thicker. They're schematically shown. Thinner thickness in root canal, cementum, and dentine in temporal teeth, and thicker in permanent teeth. What does it mean in practice? In therapeutic dentistry, less aggressive methods and instruments should be used to treat root canals of temporary teeth to prevent root perforation. Let's repeat about apical foramen. Large apical foramen in temporary teeth and narrow and constricted apical foramen in permanent teeth. Large apical foramen in temporary teeth schematically, and narrow in permanent teeth. What does it mean in practice? In therapeutic dentistry clinics, first of all, we must remember about this feature in a stage of making diagnosis. Why? As can you see, this patient has swelling on a right cheek. What primary diagnosis could you make? Doctors. Don't sleep. Please wake up. If we see adult patient with swallow check, what is the most widespread diagnosis? Complicated caries. And more precise diagnosis? No. Apical periodontitis. Acute apical periodontitis or acuteness apical periodontitis. Acute or acutal apical periodontitis. But, and of course, after opening of root canal, we will get a drop of pus, or maybe not drop, maybe more. But if our patient is child, and if you are high qualified doctors, what primary diagnosis could we make? Let's work together. We can see swelling, we can see hyperemia, redness. Please, be brave. Yes, you are right. It is complicated caries. But we know that complicated caries, it is pulpitis or periodontitis. Yeah? Pulpitis or apical periodontitis has this child. Please, your options. You are right, doctors. I never ask you so simple questions. Temporary teeth have wide apical foramen. I told you that one of many features of temporary teeth is wide apical foramen. And what does it mean? It means that in case of pulpitis, inflammation very easy spread outside of root canal through apical foramen. And child with pulpitis very often will have appearance like here. And it is very important in a complicated caries treatment. If you don't like have your bited fingers like this, doctor, in case of complicated caries treatment. We must mention very important rule. Anesthesia is mandatory. Treatment of complicated caries in temporary teeth must perform only with anesthesia. What kind of anesthesia? Local or sedation or general anesthesia? It is another question. If child is not so contact with doctor, sometimes we must use narcosis. Please mention, doctors, don't make any manipulations without anesthesia in case of temporary teeth complicated caries. Anesthesia is mandatory. You will have bited fingers, you will have stressed child, you will have unsatisfied parents. And you will lose patient and you will get bad your reputation or killed your reputation. So, what about enamel? In temporary teeth, enamel is thin and is of uniform thickness, about 1 millimeter thickness throughout the entire crown. In permanent teeth, thick and is of varying thickness. Has a thickness about 2 to 3 millimeters. Schematically, similar thickness all around all crown and near 1 millimeter, and different thickness in permanent teeth, near 2-3 millimeters. In temporary teeth, enamel is less calcified and more permeable. In permanent teeth, more calcified and less permeable. What does it mean in practice? Enamel histological features. In temporary teeth, caries develops faster and enamel defect is wider. Instead of in permanent teeth, caries develops slower and enamel defects is narrower. It is practical meaning. In the cervical region of temporary teeth, the enamel prisms are inclined either incisively, occlusally, horizontally towards the enamel surface. In the cervical region, the enamel prisms are inclined apically or cervically towards the enamel surface. Schematically, it looks like here. Horizontal enamel roots in temporal teeth and gingivally directed enamel roots in permanent teeth. What about dentine? In temporal teeth, dentine thick and is of variable thickness. Greater thickness of dentine over the pulpal wall and the occlusal fossa of molars. In permanent teeth, thick and dentine is thick and is of uniform thickness. Lesser thickness of dentine over the pulpal wall and the occlusal fossa of molars. Schematically, dentine temporal is thick and is of variable thickness. Instead of in permanent teeth, dentine is thick and is of uniform thickness. Numbers of dentinal tubules in temporal teeth dentine are less. In permanent teeth, number of dentinal tubules are more and is about 50,000, 90,000 per millimeter square. A ratio of thickness of dentine in permanent teeth is 1 to 2. Neonatal line. In temporal teeth, seen in all deciduous teeth, but neonatal line in permanent teeth present only in first molar. What does it mean, neonatal line? Do you remember, doctors? Neonatal line is an optical phenomenon produced due to alteration in the dimension, direction, and degree of mineralization of the enamel prisms caused by the biological stress imposed by a sudden change from intrauterine to extrauterine life. This line demarcates enamel formation before and after birth. Microscopically, enamel at the neonatal line is less mineralized and less organized structurally. Why neonatal lines in permanent teeth are present only in first molars? Could you tell me? Doctors? Because only first molar follicles begin mineralize intrauterine. All another permanent teeth begin mineralization after delivery. Dental enamel junction in temporal teeth is scalloped, in permanent teeth is smooth. and cementum. In temporary teeth, cellular and acellular thin. In permanent teeth, relatively thick, with the cellular cementum being thicker in the apical region of the root. Now let's talk about pulp. In deciduous teeth, a high degree of cellularity and vascularity of tissue, at least in stages prior to advanced physiological resorption of roots. But in permanent teeth, pulp comparatively less degree of cellularity and vascularity in tissue. In temporary teeth, pulp has high potential for repair. In temporary teeth, comparatively less potential for repair. Then, nerves terminate at pulpodental junction and their branches enter the dentinal tubules but end away from the dentino-enamel junction. Instead of in permanent teeth, nerves terminals transverse the whole length of dentinal tubules and end in the dentino-enamel junction. Roots have wider apical foramina and a resultant abundant blood supply demonstrates a more typical inflammatory response. Instead of in permanent teeth, foramina are restricted and reduced blood supply favors calcific response. I told you about it earlier. Then, incidence of reparative dentin formation beneath carious lesions is more extensive and more irregular in temporary teeth. But in permanent teeth, reparative dentin formation is less. Next point, localization of infection and inflammation is poorer in pulp. In temporary teeth, instead of in permanent teeth, infection and inflammation is usually local. Next point, pulp nerve fibers pass to the odontoblastic area, where they terminate as free nerve endings. But in permanent teeth, pulp nerve fibers terminate mainly among odontoblasts and even beyond the periodontium. And next point, density of innervations is less, so primary teeth are less sensitive to operative procedure. Neural tissue degenerated first during root resorption. What does it mean in practice? Practical value. In therapeutic dentistry clinics in stage of making diagnosis, using device like electrodontometer is not so good method for temporary teeth because of features of nerves in temporary teeth could give us a wrong information. And as a result, we can make wrong diagnosis. So electrotesting in temporary teeth is not so good idea. Instead of in permanent teeth, density of innervations is more, making tooth more sensitive to operative procedures.